Hi, good morning. So my name is Esther Hagai. I'm the Chief Medical Officer at Clexio. And first of all, I would like to thank the organizers for giving me the opportunity to present on CLE-100. So this is also an oral esketamine. So you may have heard already a lot of things. And I'm sorry if I'm going to repeat a few things that you have already heard. Where do I move here? No. Yeah. So this is our looking forward statement. What? It's okay. Okay, so we are developing CLE-100 as an oral formulation of esketamine. We plan to give it once daily, and we are currently developing it for patients suffering from major depressive disorder who have not responded adequately to at least 2 antidepressants. So both CLE-100, the oral esketamine, and its primary metabolite are potent NMDA receptor antagonists. They bind at the same PCP site. And our target with CLE-100 is to demonstrate that the drug is efficient for MDD patients, that is it has a rapid onset of action as compared to standard antidepressant, together with a safety profile that will allow home administration, as we understood previously how it could be an advantage for patients. So these are the development highlights for our program. So we started with the development of a proprietary formulation to deter abuse, and we are focusing on intranasal route of abuse, which is one of the main route of abuse of esketamine. Our manufacturing capabilities are established. We have done preclinical studies, so we have completed our GLP tox to enable the phase 1 and phase 2 studies. We have also completed our pharmacological studies that support our new paradigm of low daily dosing for MDD and for the therapeutic effect of its metabolites. And we are currently doing preclinical studies to enable our phase 3 programs. We have completed phase 1, which support the PK and provided a supportive PK and safety data. We had multiple interactions with FDA to be able to start our phase 2 that we are currently running in the US in MDD patients. So these slides present the 3 pillars that are behind the development of our product. So first of all, we went for oral formulation. As it was previously said, we also wanted to take advantage of the high first pass metabolism that allows to reach lower esketamine Cmax, which is associated with the neuropsychiatric and cardiovascular adverse events. We selected the dose based on comparative plasma exposure with over esketamine and esketamine products given by other route of administration. We propose to give it once daily. So instead of giving a boost twice weekly with a high dose, we propose to go with a lower dose, but daily to build up efficacy. And this paradigm allows to give CLE-100 in the home of the patients. And yesterday, we heard about the concerns about the potential risk of abuse with ketamine and esketamine products. So we are trying to mitigate this risk. First of all, because we are talking about an oral esketamine with a lower bioavailability. And so it is less attractive for an abuser that will be more prone to abuse IV or IN esketamine. And also because we have developed this innovative abuse-deterrent technology. Yeah, so the efficacy of our products comes from both the parent drug, but also from the primary metabolite, the norketamine. Both of them are potent NMDA receptor antagonists, and also from the second metabolite, the 2,6-hydroxynorketamine, which mechanism of action is still unclear, but for sure has also demonstrated antidepressant effects in preclinical models. We went for the S-Enantiomer because of its relatively high binding affinity to the NMDA receptor antagonist as compared to the Racemic ketamine and to the R-Enantiomer, and also because of the relatively high binding affinity of the first metabolite. Yeah, so S-Norketamine has demonstrated to have antidepressant effect in preclinical model, and unlike esketamine, it is not associated with behavioral abnormalities or reward effects. And also regarding the second metabolite, it has also been shown antidepressant effect. So there was a paper showing in the preclinical chronic corticosterone-induced depression models that both the primary and the second metabolite were able to reduce the enhanced immobility in the forced swim test 30 minutes after injection, and also to improve the induced anhedonia-like behavior in the female encounter test 24 hours post-injection. So showing that there is an acute and also a sustained antidepressant effect of 2S6S-hydroxynorketamine. At Clexio, we also we have also tested the antidepressant effect of 2S6S-hydroxynorketamine, and we also proved that it leads to a dose-dependently, it decreased the immobility time versus placebo in a dose-dependent manner. Yeah, so this is also preclinical studies that we conducted at Clexio in order to support a paradigm of low daily dosing. So we gave to rights either one high dose of 15 milligram per kilo one time, or the same dose, but daily for 7 days, or lower dose daily for 7 days. And if you look at the blue bars, you can see that the chronic administration of 15 milligram, so given during 7 days, produce an enhanced pharmacologic effect compared with a single dose of 15 milligram per kilo, which was shown to be an effective dose. If you look at the purple bar under the chronic treatment and you compare it to the blue bar under the acute treatment at day 1, you can see also that the chronic lower dose of 7.5 milligram per kilo is producing an effect that is comparable to a single effect of a higher dose of 15 milligram per kilo. So this was the basis for the development of our oral esketamine. Yeah, regarding the strategy of our formulation, so we have developed a proprietary abuse-deterrent formulation of esketamine. We have discussed all the in vitro abuse-deterrent testing studies with FDA, and we have already completed them. We were able to show that the API, the parent drug, cannot be separated from the excipients even after manipulating the powder, which means that an abuser would have to insufflate the whole tablet of esketamine, which is mainly comprising excipients. We also checked the in vitro simulation of a nasal absorption, and we show that a negligible part of esketamine is recovered. So these are our phase 1. So we did a phase 1 with a single, it was a single dose open label crossover trial in 16 healthy volunteers. And since it was a crossover, every healthy volunteer received the four following treatment in a different sequence based on the randomization. So they received 20 milligram of CLE-100, 100 milligram of CLE-100. They received 20 milligram IV infusion of Keta, which is the approved S-Ketamine solution in Europe for infusion. And we also gave them this 20 milligram solution to drink. So we wanted to compare the safety and the tolerability of oral and IV esketamine, and also to compare the PK of esketamine and its metabolites after oral and IV administration. So regarding the safety, so even up to 100 milligram, the administration of CLE-100 was safe and generally well tolerated. We didn't have any SAEs. We didn't have severe TAEs. The vast majority of the adverse events were of mild severity and they were transient. The adverse event that we observed in more than 2 subjects. So we have, sorry. Just a second, I'm sorry. So in the 20 milligram tablet, we had headache, hyperhidrosis, myalgia, dizziness. And in the 100 milligram, we had headache, feeling abnormal, nausea, vomiting, some oral paresthesia, and some euphoric mood. We didn't have any findings regarding the labs, the vital signs, the ECG, no suicidality, no psychotomimesis based on the CSSRS or the BPRS. We saw, as expected, that we had more adverse events with 100 milligram of CLE-100 than with 20 milligram. And also, as expected, we saw much more adverse event with 20 milligram IV as compared to 20 milligram of CLE-100. This is our PK, so for esketamine and for the primary and the second metabolite. And so what we saw is that following oral administration of CLE-100, esketamine is rapidly and completely absorbed. We measured the bioavailability, so it was 8% for 20 milligram and 14% for 100 milligram. And if you look at the Cmax of CLE-100 20 milligram versus 20 milligram IV, you can see that we are reducing the Cmax by 8 times. This is what we were expected, so it confirmed our assumptions. And however, and as we also expected, you see that the exposure to the metabolites is completely maintained. So we are now conducting our phase 2. This is a 2-part study. We have already completed the part A, which was an inpatient study, and we are now in the double-blind placebo-controlled part of the trial. So the part A, we designed it as a 1-week inpatient double-blind treatment period. The patients were hospitalized for 1 week, and then they were followed up for an additional week. We included patients aged 18 to 16 years old with a MADRS score of equal or higher than 18. They were all with a diagnosis of MDD without psychotic features, and they were all on a stable dose of oral antidepressant. We included 16 patients. We randomized them to 40 milligrams CLE-100 for 13 patients, and we gave placebo to 3 patients, and they had all to take it on top of their current antidepressant. So we did extensive safety assessment, as it was our aim to show that we are going to be able to give CLE-100 at home. So we did repeated assessment of blood pressure and heart rate, of somnolence, sedation, using self-report measure of somnolence and the MOS scale. We looked at dissociation, psychotomimesis repeatedly using CAT and the 4-item BPRS. We looked at cognition, short-term cognition immediately after dosing using the DSST and the Cogstate computerized battery of cognitive tests. We look at suicidality. We look at withdrawal symptoms 1 week after study drug discontinuation. And we did all the ECG labs, etc. And also, we asked the patient and the investigator at the end of the 1 week inpatient whether they think that this drug can be given at home safely. So these are the demographics. So the average age was 15. Most of the patients were male. We had also a majority of Afro-American people. We did this study in one site who had, in general, a lot of Afro-American patients coming to studies. Non-Hispanic and non-Latino were predominantly enrolled. So regarding the safety results, so we didn't have any serious adverse event. We didn't have death. We didn't have serious adverse events. We didn't have any patients early terminating the study because of an adverse event. We didn't see any adverse event of dissociation. We didn't see any psychotomimetic signs. All the CAT scores were below the threshold of clinically significant dissociation, which is 4. We did not have any findings on the 4-item BPRS scales at any time point. We didn't see any increase of blood pressure or heart rate after the dosing. We didn't have adverse event of sedation or somnolence. We didn't see any pattern of cognitive decline. No increased suicidality, no withdrawal syndrome 1 week after discontinuation. And interestingly, when we asked the patient and the investigator whether they would take this drug at home and think it's safe, all of them responded positively. So based on these results, we were able to proceed to part B, which is an outpatient study. So the part B intends to now assess the efficacy and confirm the safety of 40 milligram in MDD patients who have not responded adequately to previous antidepressant. Yeah, so this is the study design. So we are enrolling 122 patients. There is a screening period of 28 days, and then they are randomized to either CLE-100 or placebo in a 1:1 ratio. They are receiving the treatment once daily, for 4 weeks, and then there is a follow-up of 2 weeks. So we are including patients with a primary diagnosis of MDD without psychotic features. They have to have a MADRS score equal or higher than 24 at screening, and we are requiring at least 2 inadequate response to antidepressant therapy in the current major depressive episode. We exclude patients with more than 5 failure. We consider that this is a very refractory patient population. So our primary endpoint is the MADRS at week 4. And we were also very interested to look at patient reported outcome. So we are looking at functioning. We are very interested in functioning. We believe that this is very important. And we believe that our drug, like other Esketamine and Ketamine product, can have an effect of functioning. So we are measuring the Sheehan disability scale. And we are also looking at the self-depression questionnaire. We want also to hear the patient voice. We want to understand what the patient is thinking about our product, and not only the MADRS. As it was said yesterday, the MADRS may not be the best endpoint to measure depression. Unfortunately, this is the regulatory endpoint, so we have to put that as a primary endpoint, but we are very interested in hearing the patient voice also in this study. We are looking at the CGI-S, and we also have put the MADRS at week 2 as a secondary endpoint because we want to ensure that we will capture when the treatment starts to work. Yeah, so this is the next step. So we are expecting the results from CLE-100, that's the phase 2 study, at the end of the year. We will start phase 3 program in MDD, probably end of 2023, if everything goes smooth. We are planning our human abuse liability studies to be conducted in parallel with phase 3. And we are also planning additional phase 2 in bipolar depression. We also believe, based on the literature and on the real world data evidence, that our product can also be efficient for bipolar depression and not only for unipolar depression. Thank you.
Any questions? Thank you. Right, yes, questions. Rupert, we'll start with you.
We heard earlier the negative results of the study that was the same drug 3 times a day. Optimistic are you that 40 milligrams once a day is going to do the job?
Yeah, that's a good question, and I would say that I would have been happy if the results would have been more positive. But really, I think that there are a lot of difference. So first of all, it's a different dosing schedule. It's 3 times a day, and we are giving once a day. Maybe this makes a difference. I don't know. We will see that. I think that the difference also in the population. I think that we are going for a much less resistant population. And that's why I asked Robert, previously, whether you thought that the population was not particularly resistant. We are using a different endpoint, so the MADRS, and I think that the MADRS, although it's not the best endpoint also for MDD, I think that for ketamine and Esketamine product, it may be more adapted than the Hamilton. That is maybe better for sedative antidepressant like other companies have. So we are still optimistic, and in a few months we are going to get the clinical data, so we will get an answer. But obviously, it's a good question.
Thank you. Yes.
Medical University of Poland. It's like very promising. Just 2 issues came to my mind. Was there any specific backbone antidepressant that you pre-specified, like SSRI, SNRI, or any approved treatment? And the second case is like, if we don't put this into like a dichotomy of adverse events reporting, did you observe slight increase in blood pressure across the administration that was, self-limiting time? Because, it is very not frequently seen that you don't see, blood pressure elevation after, right, at least in proportion of patients.
Yeah. So we allow almost every antidepressant except the MOA inhibitor. So yeah, we can get any SSRI, any SNRI, 3 cyclics, and other antidepressant. And regarding your first question, so in the in the phase 1, we give up to 100 milligram, and there were very slight increase in blood pressure, but nothing clinically significant. With 20 milligram, it was completely flat. In part A, with 40 milligram, it's flat.
Yes.
Just a quick question. Do you plan to have UK as a site, as a country to recruit for any of your future studies?
Yeah, probably for the phase 3 programs, we will need to extend to go abroad and not just focus on US, because there are plenty of MDD studies in the pipeline and the sites are overwhelmed. So we will go to European countries. I don't know if UK will be one of the countries, but it will be certainly assessed.
Thank you. There's a question over there.
Hi, Josh Rosenblatt from Toronto. Thanks for an amazing presentation. I was curious about your thoughts around mechanism of action of the oral ketamine, S-Ketamine formulations that we've been hearing about all morning, compared to the IV, where in my mind, in many ways, it might be that both are effective, but it seems like they're almost completely different drugs, where the idea of having very high doses with IV intermittently versus low doses daily. So curious if you can comment on that in terms of any thoughts that you have in the development, if you're thinking that this is the same mechanism of action as what we see in IV ketamine, or really quite a different angle that could still.
Yeah, so obviously we are all targeting at least some of the mechanism of action relates to the NMDA receptor antagonist, and there are other pathways that are more or less activated by the different products. I think really the oral esketamine, oral ketamine are really relying on the high first pass metabolites, and we count a lot on the efficacy that will come from the metabolites, from the first metabolite and probably the second metabolite. So that's the big difference. And on the other hand, we want to reduce the Cmax of the parent drug to have a better safety profile. So that's really the big difference between the two routes of administration.
Thank you. Are there any more? Oh yeah, Marianne, go for it.
Mario Girena from King's College. Have you seen major difference between doses in phase 1 with healthy volunteers? The same with patients that
In terms of side effects?
cognitive function.
Regarding cognitive function, so I'm not able to disclose now the results, but we will have some results, and we assess that both in healthy volunteers and in patients. But the sample size are quite small, so we will wait for the end of the phase 2 where we have more data about cognitive function. This is also one of the endpoints, which is of big interest for us.
Great. We'll take one more question. Yeah, Anya, go for it.
How long a time period will you be looking at the phase 3? Like, are you planning to look at longer than 4 weeks, just in terms of, I guess, the...
So it should be also 4 weeks treatment for the phase 3.
Do you have any plans to look at longer timescales, I guess?
Yes, it's also on our plates. We start with induction and we will look at maintenance.
Great. Thank you very much. Well, that's the end of this first session. So thank you again to our last speaker.